All right, and is everybody able to see my PowerPoint?
Yep.
Perfect. Yep. All right, so tonight what we're going to do is I'm going to kind of touch on some of the stuff we covered last week, because I feel like with this topic, especially a good review will actually help everybody. I'm going to add in some new stuff, such as cardiac arrest rhythms, maybe our junctional rhythms. We're going to talk about paced rhythms, and kind of go from there, and throw in ventricular rhythms as well. So I don't want to throw a whole lot, but as long as we can get the basis of the foundation of, what a P wave is, what a QRS complex is, what a T wave is, and our durations, that's pretty good for where we are at right now, and knowing what those numbers mean, and knowing what one small square box is and one large square box. So again, if you have questions during, please ask, because it's going to do you no good 5-6 weeks down the line when you have questions and you could have asked them in class, and now we have to backtrack a little bit. It's a little bit harder to kind of catch up at that point. So this PowerPoint is actually one that I teach a couple times a year, maybe 3-4 times a year, for nursing students, or for people that just need kind of a refresher that can sign up for the class through the college. So I thought it'd be a good opportunity for me to touch on some of the stuff we went over last week and explain some of the stuff, and maybe explain some of the concepts. I do have one video in here. It's I believe like a 12-minute video. I might save that till the end, but it's pretty early on in here. But it talks about EKG interpretation and what is best for some people, and how methodical some people are in the process that goes into it. So we know that an EKG or ECG, either or, doesn't matter what you say, is essentially electrical impulse. That's all we're looking at, is electrical activity within the heart. We're not looking at mechanical. If we want to verify mechanical, we check for a pulse in a patient and verify that it matches what we see on the monitor. But we're just looking at electrical activity in hopes that, remember, electricity stimulates muscle, so we get that squeeze with the heart every time we get a depolarization, or I call it lightning bolt. Don't pay so much attention to the picture because it's really blurry, but different parts of the heart, obviously, we have two upper chambers, right and left atria, that squeeze together simultaneously to push blood through our tricuspid valve and our bicuspid valve. Tricuspid being on the right side because the letters RI are in tricuspid, so that's right. Mitral is another term for bicuspid valve. Down into our ventricles, where the blood is built up under pressure. Remember, the farther the heart expands, the greater it's going to squeeze, kind of like a rubber band, until they pump blood to where either we're going to the lungs or we're going out to the rest of the body. A good thing to remember as well is that with our heart, this portion right here on the screen, our left ventricular wall is going to be more muscle dense than, say, that of our right side here. Why is it more muscle dense? Somebody give me the answer on that.
More workload.
It's got to work harder, right? More workload. So the left side of the heart has to push all this blood out to the body through our arteries, right? As to where our right side of our heart just pushes blood to our lungs. So it's essentially a low pressure system going to our lungs, as to where it's more of a high pressure going out to the body. This is the video I'll save for the end. That way it might sum up some of the stuff that I talk about a little bit. And if you have questions during that, ask as well. The heart, we receive oxygenated blood and we receive deoxygenated blood. Blood's not blue. Again, on diagrams, that just it represents deoxygenated blood. Once the blood goes into our lungs, we get that exchange of carbon dioxide and oxygen, and then we come back oxygen rich, back to the body to be pushed out to where our organs would need us, our skin, our integumentary system, whatever bodily functions would require oxygen. This will become very important. So, and I think, I believe I put a worksheet on D2L, and it will end up being homework. I put two different worksheets on there. I put a heart diagram labeling, so like the different parts of the heart, and I also put a coronary artery labeling sheet. And why this is important for us as paramedics to know, or for us to essentially be able to identify, is because that'll really tell us what part of the heart the person is potentially having a blockage, or the person is potentially having injury. There's three big terms when we talk about somebody maybe potentially having a heart attack. At first we have ischemia, which is lack of oxygen, so low O2. Then we have what's called injury, which comes right after ischemia. And then after injury, we have tissue death. And those are all things that we can see when we begin to look at 12 leads and tear apart 12 leads and look at different coronary arteries. So it's really important that we look at these arteries and know what they're feeding, what muscles they're feeding, how they're feeding them. Because I can look at a lead right now, I can look at a 12 lead and say, okay, this person's got a heart blockage right here. It's preventing blood from going in this artery, and it's preventing blood from going in this artery. We should be able to do that as paramedics and know potentially what is going on with our patients, and that'll alter our treatment as well. Such as in a right-sided MI, so if I point to my right coronary artery here, what do we have to be cautious giving? What medication do we have to be cautious giving in a right-sided MI?
Nitroglycerin.
Nitro.
Okay, why is that though? Why do we have to be cautious with it?
Reduces preload.
Because it decreases preload.
Yeah. So we already have a heart that's infarcting. Look at this as the artery. It's got a blockage, right? So our flow is reduced a little bit. Everything in blue down there is how much blood we have filling that artery. Not a lot, not even halfway. If I give nitro and I make that vessel bigger, I didn't change the fluid. So now that fluid is only occupying this much space. So I'm going to drop my patient's blood pressure. Kind of makes sense if you think about it, why we don't give nitro, and it kind of makes sense why we are, potentially looking at giving these patients fluid before we give nitro. And you'll notice that as well, is that it really falls down to different medical directors and different protocols as to if we're going to give nitroglycerin or not, based off what the patient's blood pressure is. If you talk to like Dr. Poole, Dr. Carrion, they will absolutely say 100% give nitro, as long as we have IV access and the ability to give fluids to rehydrate this patient if needed. I'm not going to hit the blood flow. It's pretty basic. All right, so when I talk about a cardiac cycle, if you hear me refer to cardiac cycle, what I'm referring to is the atrium squeeze, the blood pass through the valves into the ventricles, out to the body, and then resetting. And I can see that by looking at an EKG. Get my pen pulled back up. So atrial squeeze, ventricles firing, everything resetting. When I refer to a cardiac cycle, this is what I am talking about. That is one complex. That is one heartbeat. That is one time that each muscle in our heart has had stimulation and contracted in some way to produce blood flow to our body. Remember, systole is obviously the amount of high pressure, the amount of afterload. When we think of systole and diastole, the easiest way I can put it is 120/80. Systole refers to our systolic number when the heart is actually working. Diastole refers to the bottom number where our heart is relaxing, how much blood we have moving around when we're relaxed. So one thing that I don't want you to get out of the mindset of doing is checking a pulse on your patient. Even if a patient is on a cardiac monitor, if they're on a 3-lead, if they're on a 4-lead, whatever it is, verify that by checking a pulse. Check a radial pulse. Check a brachial pulse. Check a carotid pulse. Does anybody remember our kind of rule of thumbs or rules of thumb, whatever you want to say that, for what a pressure is depending on the location of the artery? Anybody remember that?
Isn't it if they have a radial pulse, it's at least above 90?
So we'll say this. Radial is, a good rule of thumb is 80 systolic. If it's a brachial pulse, good rule of thumb is 70 systolic. If it is a carotid pulse, it's at least 60 systolic. Why that's important for us to know is I've had patients before that were literally tanking on me, but before I could get them on a monitor or anything else, I could feel for that pulse and know that their pressure was at least that. So I knew I had a pressure of at least 80 systolic to work with at that point. The heart normally beats 60 to 100 times a minute. Does anybody remember what the primary pacemaker of the heart is called that beats 60 to 100 times a minute?
The SA node.
Yeah, SA node, right? That is super important for us to remember, is that our SA node, or our sinoatrial node, is what we consider our primary pacemaker. Now, we do have backup pacemakers if our SA node fails, but that is our go-to when it comes to electrical activity. That's what starts this little party of electricity that travels down our heart. And remember, any rhythm that originates from the sinoatrial node, we consider a sinus rhythm. It's just a way of saying, hey, I know this is a regular rhythm. I know this is a bradyrhythm. I know this is a tachyrhythm, but I know it's coming from my SA node. So whenever you see the word sinus, think SA node. Cardiac output. Does anybody, when it comes to our equation, remember how many liters of blood our body has on average inside of it?
So 6?
Well, yes. 6 is a good number. It's generally between 6 to 7 liters is how much blood we have inside of our body at any given time. So our heart has the potential to squeeze between 4 and 8 liters per minute. So literally in 1 minute's time, every ounce, every drop of blood that we have within our body is being moved around. Different parts of our electrical conduction system. So we have our SA node. I'm going to label that 1. You can see the arrow right there. That is the primary pacemaker. So remember, we get all these little cells, like so, around there. They get excited. Once one cell is excited, that excitement can travel between the cells, and they start to go on a road trip. They start to go on this little road trip down to our AV node, which I will label as 2. Now, what happens at our AV node? Does anybody remember? What happens to our electrical impulse?
Slow down.
What was that?
Get slowed down.
Yeah, absolutely. We take that really fast impulse and we put a, kids at play sign in front of it and say, hey, slow down a little bit. So our SA node, we know, fires at a rate of 60 to 100.
And I think our AV node fires between, is it 40 to 60?
It is 40 to 60. Good job. Our AV node, or you might also see it called like a AV bundle, possibly, will fire between 40 and 60 beats per minute. So that's always in the back of my mind, is that if I have a patient with a low heart rate between 40 and 60, is this still a sinus rhythm, or is this a rhythm coming from their AV node? Now, the big way I can tell is, remember, on a strip, I will have a P wave, right? Indicating atrial firing. We'll put 1 so it correlates to the diagram. If I have a rhythm that does not have that, oh, such as no P wave, that is coming from the AV node because I don't have that P wave. I don't have that atrial kick.
So that's what you see in atrial flutter and atrial fib, correct?
Not so.
Because there's no
atrial
P
fib-
waves.
in layman's terms, yes. And also in AFib and a flutter, it's really just because the rhythm is like bouncing all over the place, so that you might not really be able to discern a P wave that's embedded in that rhythm. Because P waves can hide within complexes, they can hide within T waves. Especially when we look at like our heart blocks, we can have them hidden in some of those rhythms. And it really just comes down to us kind of paying a little attention and looking a little bit further into it. So going down our heart, we have this electrical impulse. So we've slowed down from here. We travel down these bundle branches where this electrical impulse is spread out to our muscle, into our Purkinje fibers or our bundle branches. Now, the bottom of our heart is really wide. It's really muscular. So let me do this. Any rate coming from our bundle branches, I'll put BB, is a rate of 20 to 40. Now, I want you to remember something. The bottom of the heart is wide. Again, very muscular. So any rhythm that comes from the ventricles is likewise wide. Maybe not so much muscular because we can't see that, but they're really big, wide, ugly rhythms. And I'll have examples of that as well. But this is pretty important for you guys to know. Is our different, they're called intrinsic firing rates. The different rates that our heart fires. So, God forbid, my SA node here, I put an X on it, my SA node fails. Okay, I will then resort to my AV node taking over. And my AV node is going to fire at 40 to 60 beats per minute. And I will have this without a P wave because sinoatrial node is not working. Now, if my AV node fails, I do have yet another backup, which is my ventricles, my bundle branches. And they fire at a rate of 20 to 40. But just remember, they are a very wide rhythm when it comes to the ventricles. If you've ever heard of like ventricular tachycardia or an idioventricular rhythm, which I have examples of here later on, they're kind of nasty, kind of ugly looking. Everybody following me so far?
Yes.
Perfect. So we know basically what these points are within a complex. We know what these points mean. Here's a little circle diagram for people like pictures. I'm a picture guy. This makes sense to me when it comes to what these different segments, what these different points mean, such as our P wave, our QRS segment, our T wave. But there's some other things here we need to know as far as numbers. And those numbers we need to know are our PR segment and our QRS segment. And remember, I'm looking for time. When we talk about EKG paper, they represent distance and time. As we go down a strip of paper, that's the longer distance it's taking, the more amount of time it's taking. Does anybody remember what a normal PR interval is? This guy right here. Does anyone remember what those numbers are supposed to be? What was that?
0.12 to 0.2.
Okay, so 0.12 to 0.2. Okay, in terms of boxes, how many small boxes is that? Remember, one small box equals 0.04.
3 to 5.
So I've got 3 to 5 small boxes. All right, QRS duration. What's our normal numbers there?
0.08 to 0.12.
0.08 to 0.12, which is 2 to 3 small boxes. Those small boxes, I can not beat this in your head enough, represent time. Each one of those small boxes represents time. So, and again, I'm going to keep hitting this for a reason because this is vital that we know this as paramedics. I can't tell you how many people go to take the National Register or go to take a test and they don't understand how to read a 4-lead or don't understand how to look at this and break down what's happening within the heart. If you can't do that, then it's going to be rough passing any sort of test or acting as a paramedic. So P-wave, atrial kick or atrial systole, that's when we squeeze, right? We have our Q wave, which is where atrial systole ends. That's where our atrium resets. We have our RS complex, R and S, which is our ventricular squeeze. We have this little bit of rest period called our ST segment. And then we have our T wave, which is control alt delete of the heart. That is everything resetting just to go through it all over again. Now, and I'll just plant this in your brains for now, when we get into 12 leads, probably next week is we're going to start. When we get into 12 leads, this ST segment is huge when it comes to 12 leads because that's how we determine injury, ischemia. That's how we determine if somebody's having a heart attack. It is the area between our S wave and our T wave, your ST segment. There is no set way on how you have to interpret a rhythm. Whatever works for you will work. I'm not saying you have to look at the P waves first. You have to look at the QRS complex first. You will figure out your own way of doing it, whether it's, hey, this is a narrow rhythm or this is a wide rhythm. And what I mean by that is any rhythm that is narrow is coming from above the ventricles. Any rhythm that is wide is from the ventricles. Narrow is regular to me. Wide means something is going on. I covered this already. I cannot say this enough as well, and this is one thing that even paramedics today fail to do, and that is treat your patient. If you've ever heard the term treat your patient, not the monitor, I've literally had patients that I look at the monitor and it's terrifying, like something like it horrible, but my patient's acting fine. It's kind of odd. When we read a strip, we always start at this end and work towards this way. Some of the things that should be included in our interpretation process, and again, you do these in your own order or whatever seems fit for you guys. We need to know the heart rate. Is it 60 to 100? Is it above 100? Or is it below 60? Any rhythm that is above 100 we can classify as what?
Tacky.
Tacky.
Right? Easy way that I remember, if anybody knows what that gauge is called in your car that measures your speed, speedometer, and then you have your tachometer as well. So when you rev your car up, your tach will move. Below 60, what is that rhythm called?
Bradycardia.
Okay, Brady, right? We need to know the rhythm. And what I mean by rhythm is there's only two things I want you to look at. Is it regular or is it irregular? That is it. I don't want you looking any further into it than that. Do I have complexes that are equal distance from each other? or are they irregular in distance and time? Do I have a P wave? Does every complex have a P wave? And then last but not least, my PR interval and my QRS complex. What is my PR interval, knowing that, it's that 0.12 to 0.20? If it's less than that, it's not a huge deal. If it's longer than that, we could potentially have a block, because remember, if I have a complex like such, and this equals, 0.2 seconds, and then I have a complex as such, that's a horrible strip, and this now equals 0.4, that means it's taking that much longer to move down my heart. There's something wrong, whether it be a heart disease, whether it be electrical pathways not firing correctly. Something is wrong, causing a delay.
I will.
I bought a multi-thing, so heaters and went down and I'm recording.
How we determine heart rate, obviously you can pay attention to your monitor. Easiest way that I've showed you guys is if you have a 6-second strip, remember those 3 lines on your piece of paper, count the number of complexes you have within that strip. Multiply by 10, and that should give you your heart rate. So at that instance there, I have 1, 2, 3, 4, 5, 6. 6 times 10 equals 60 beats per minute. Now you can look at your atrial rate and you can look at your ventricular rate, but I don't want you guys looking at that right now. Atrial rate would be how many P waves do I have? Okay, they should match. If I have 6 complexes, I should have 6 P waves, but sometimes that's not always the case. But as of right now, I just want you counting complexes. Another example. Somebody give me an example of an irregular heartbeat.
AFib.
AFib. Okay. Why is AFib, and we went through this today with some students, why are those patients on blood thinners again that are in AFib?
The heart's not pumping blood effectively.
Okay, not pumping blood effectively. So let's just say I have a complex here, and then I have one here, and then I have one this far, and then here, and then here, and here. It's not regular. My complexes are all over the place. So between here and here, I'm not really allowing blood to fill, right? So I'm going to squeeze that blood out really quickly. As opposed to here and here, that blood is going to sit in the heart for a lot longer period of time. And our concern is that we can essentially form a clot, and the patients in AFib can throw that clot and potentially do a stroke. That's why patients in AFib are on blood thinners such as Coumadin. So, and that's something I told the students today as well, is look at your medications. And that's something I do with my patients first, is I look at my medications and I try to determine their medical history based off their medications alone. So, for example, looking at different potential medications, if you were in my class today, don't provide input on this, but if I had a patient that is on metoprolol, simvastatin, and Coumadin, what do I know about that patient's medical history? Just based off those 3 meds.
Some sort of
They're
cardiac.
on a high blood pressure medication. They're on a beta blocker and a blood thinner.
Okay, so we know Coumadin is a blood thinner, so we'll just put BT. So I could potentially say, and the one thing I always ask when I see that is, hey, do you have an irregular heartbeat? They don't know what AFib is, but if you say, do you have an irregular heartbeat? They're like, oh yeah, I have that. Metoprolol. Remember, anything that ends in LOL is a beta blocker. used to treat hypertension. What about this last one? And I'm going to
High cholesterol med.
That's exactly what it is, cholesterol. So I'm just going to put HCl for high cholesterol. Anytime you see medication with the word statin in it, that is always going to be a cholesterol med. So this patient I have on Coumadin, metoprolol, and simvastatin, I can definitively say, okay, this patient has a history of AFib, they have a history of hypertension, and they have cholesterol issues. And then I'll ask them about their history, because now I have something to lean into. Again, does our rhythm have a P wave? I'm not going to beat that horse. Do the P waves look alike? And there's a reason for that. When we get to 12 leads, it'll make a little bit more sense, but our P waves are all supposed to look uniform when it comes to our complexes, right? If we have a P wave that looks like this, and then one that looks like that, and then one that is upside down, that becomes a little more of an issue, because that electrical impulse is not following the same route every time. Each route will have its own identifier, such as how your P waves look. So we could potentially say, you know, that patient's pacemaker is wandering. If you ever heard of a wandering pacemaker, that's what that is. So, knowing what we do, normal sinus rhythm has a P wave that is within its 0.12 to 0.20 for a duration. I've got a P wave for every complex here. Mr. Robinson, does this look like a regular rhythm or irregular?
That looks regular.
Okay, it looks regular, right? So I know it's a regular rhythm. Let's say the heart rate on this patient is 62. And my complex is narrow. That's all I'm looking at for a sinus rhythm. And you can call this NSR, or if you've seen it documented as NSR, it's just abbreviation for normal sinus rhythm. Or some people, you know, especially if I'm giving a report to a nurse, whatever, I'll just say the patient was in a sinus rhythm. No abnormalities were seen. That just tells them that, hey, everything appeared normal. There was nothing out of the ordinary that I had to worry about at the time. All right, so 6-second strip. We're going to use this as a practice strip. There's my 3 lines showing it's a 6-second strip. Somebody tell me my rate without looking at the bottom here.
100.
Okay, we've got 10 complexes, so I've got a rate of 100 beats per minute. Kudos to you for counting, because I put the wrong number at the bottom on purpose. Rhythm, regular or irregular?
Regular.
Okay. My PR interval, just from looking at it, how many, let's see if I can zoom in. How many small boxes do I have between my PR interval and my QRS complex?
Two.
So your PR interval actually starts halfway in the P wave. So roughly 3 on this case. So what's 3 small boxes equal in time?
0.12 seconds.
What was that?
0.12 seconds.
0.12 seconds, right? Okay. Now, is that narrow or is it wide
Narrow.
as far as the QRS complex?
Narrow.
Yeah, narrow. Okay, so what would you call this rhythm?
Sinus tech.
Normal sinus.
So 60 to 100 is sinus rhythm. If it's at 100, I usually will err on the side of caution, sinus, and call it sinus tach. You could be right either way by calling the sinus tach or NSR because you're right at the boundary line. But I also can see that I have a P wave and I have a T wave for every complex, so not too concerned there. Looks very familiar. Looks like the one we just went through, right? Sinus tach, again, is just a rate faster than 100 or 100 or greater. Sinus Brady, and don't let this freak you out. A lot of people look at this jumble and go, what the hell is that? Don't let it freak you out. That's just the heart resetting. I want you to pay attention to your P waves, your QRS complexes, and your T waves. What is my rate with this patient?
40.
Okay, 40. Narrow or wide?
Narrow.
Narrow. And that can trick you up because you can look at that and want to say wide, but it is still narrow. This is the one that is most commonly misdiagnosed or misinterpreted is SVT. And again, the easiest way I can tell you guys, and remember, SVT is a fast rhythm, right? Some people will say anything over 140 beats a minute. Some people will say anything over 150. Some people will say anything over 160. It depends on the cardiologist you talk to. And what you'll soon realize is that you can ask 5 different cardiologists the same question and you're going to get 5 different answers. The big thing for me to determine if this is SVT isn't the rate. I know it's fast by looking at it. It's the fact that I can't tell if that's a P wave or a T wave. It's going so fast that I can't tell if that's a P or T wave. So what is the rate on this?
180.
Okay, 180 beats per minute. Now let me ask you guys this. What's a concern if I have a patient whose heart rate is 180 beats per minute?
It's not allowing the heart to properly pump out blood or refill with blood.
Yeah, it's not letting the heart truly refill with blood because it's moving so fast, right? So I could potentially see in this patient lower blood pressure. Medication-wise, and remember, when it comes to tachyrhythms and bradyrhythms, we have unstable versus stable. In stable patients, or patients we're going to use medication in, we use adenosine. First dose is 6 milligrams, followed by 12 milligrams if needed. And it is a rapid push. And when I say rapid push, the couple times I've given adenosine, honestly, I use a 3-way stopcock. I put the adenosine on one of those valves. I put a flush on the other one. I slam adenosine, slam the flush right afterwards. Just, again, it's a very quick drug. And you guys remember my horror story. What happened with my patient that I first gave adenosine to is that they will have a period where they will potentially flatline for 3 to 4 seconds before they pick up. And our hope is they will go into a sinus rhythm. No more SVT. Let's break down the word SVT. Okay, so let's look at supraventricular. What does that mean?
Too fast.
Nope. There's something. Nope.
Above the
Above the
ventricle.
ventricle.
Above.
That is exactly what I'm looking for. This is a fast rate above the ventricles. That's all supraventricular means, is above ventricles. AFib, again, this is, I swear, one of the most commonly seen rhythms. And it should be a really big indicator for us is if our patients are on Coumadin or warfarin
Or Eliquis.
or Eliquis. Okay. Irregular or regular.
Irregular.
Irregular.
Okay. Do we have a P wave from what you can tell?
No.
And if we do, not all of them do, right? And that's okay. In AFib, that's expected because that impulse is coming from different points in the heart. You'll literally see the heart rate jump from 60 to 90 to 104 to 123 to 134, back down to 60, because it can't pick up on where it's firing from. AFib will still have a narrow complex. It will not be wide because the first word in AFib is atrial. So it's still coming from above the ventricles. Generally, this isn't a rhythm we're going to have to treat. Some patients, if they have a new onset of AFib, or if you know anybody, does anybody have any family members with AFib or anything like that?
Yes.
Okay. Have you ever had it to where they felt dizzy or felt like they were going to pass out?
Absolutely.
Okay, that is due to this short period between these complexes right here, where the heart isn't refilling, so it's not able to squeeze out a lot of blood. So that feeling is literally reduced blood supply to the brain. That's why sometimes if you have a patient has a new onset of AFib, they could have passed out, or they could have had to sit down because they were feeling really dizzy. Those are really good indicators to put your patient on a cardiac monitor. Anytime you see dizziness or syncopal episodes, whatever it might be, just identify what's going on with your patient. And a lot of times, seriously, you can ask them, have you ever been told you have an irregular heartbeat? And they'll say no. Well, you might have just found what was going on with your patient.
So, Rudy.
Yeah.
So I just went through this recently.
Mm-hmm.
The doctor didn't put my mom on a monitor, and I asked for a monitor.
Yeah.
So she got a pacemaker today. So.
Oh, sure. And due to, I'm guessing, was her heart rate just really low, or?
No, she was actually between 250 and 300, but she was having sinus pauses, 5 to 6 seconds. So.
Okay. That is a fast rate. Wow.
Yeah. She was supposed to get her pacemaker replaced on Wednesday. They bumped it to Tuesday. So that's why I didn't come today for.
And we're actually going to go through pacemakers here shortly. So that might make a little more sense when we start talking about certain different types of pacemakers. Again, with these patients within AFib, treatment-wise, unless they're symptomatic, just treat them supportive care, right? And when I say supportive care as paramedics, we're going to start an IV, might give oxygen if their oxygen level is below 94%, fluids if needed, if their pressure is not withstanding, and then monitor their cardiac rhythm, monitor their heart rhythm on the way to the hospital. What you'll hear me say, I don't know how many times, is a word called serial 4 leads or serial 12 leads. When I talk about that, it is meaning constantly monitoring your patient on the way to the hospital. And it's something we should be doing. So a flutter, what is the thing that really sets a flutter apart from any other rhythm?
Shark tooth.
Shark teeth, right? Our P and T waves, where they should be, we have shark teeth. Now, if I wanted to go even more in depth and say what type of a flutter this would be classified as 2-to-1 because I have 2 flutter waves for every complex. If I had 3 flutter waves, it would be 3-to-1. If I had 4, it would be 4-to-1. That makes sense? So 4-to-1 would be literally 4 and then a complex, and then 4 in a complex. Again, patients in this rhythm, treatments that we have, it's going to be treating the patient, not the monitor. We're going to be supportive. We're going to treat the patient as needed. Maybe they need fluids. Maybe they need something for nausea, whatever it might be. We're going to be supportive. All right, let's take let's take a 9-minute break. We'll come back at 7 o'clock because I'm going to jump into a new portion here that kind of confuses some people. So 7 o'clock, we'll come back and continue. And like I said, we should only go till 8:15 roughly tonight. All right, guys. So in this section, I know I talked briefly on it last week, and again, I felt like a review was needed because I covered a lot of ground last week, and I'm just kind of throwing the pertinent stuff at you now, and then I'm gonna throw in some newer stuff here shortly. Some abnormalities that we can have are PACs, PJCs, or PVCs. So a PAC is a premature atrial complex. And that just means when a whole complex fires sooner than it should. Comes from the sinus node, SA node. So there's a P wave to it. We can have a PJC, which comes from the AV node. So it will not have a P wave, but it's still an early complex. And then we can have a PVC, which is a premature ventricular complex. And that would be maybe somebody that drank a lot of caffeine, that smokes, had a lot of sugar, and they throw a ventricular beat every now and then. Again, can cause lightheadedness and cause dizziness, but I'll show you what this looks like. So a premature atrial complex will look just like AFib, right? And you're not wrong to call it that. But if you look at all my complexes here, do I have a P wave for all of them?
Yes.
Okay. So I'm hard pressed to call it AFib at that point. Are all the complexes narrow?
No.
Where do you not see a narrow one? I'd say they're pretty narrow.
Yeah, sorry.
No, you're good. You're good. But so I look at this right off the bat and I say that's AFib. That's an irregular heartbeat. And you're not wrong to say that because that's your quick glance. But if you want to look a little further into it, I say, okay, the distance between this QRS complex and this one is pretty much the same. The difference here is real short compared to the last ones. The difference here is real long compared to the last one. But then I go back to normal distance between them. Can you tell me which beat is sooner than what it should be? Just count from the left and tell me which one you think.
Fourth one.
Fourth one. So 1, 2, 3, fourth beat. And that's exactly right. That beat fired earlier than it should for some reason. And it still has a P wave. So that is what we would classify as a premature atrial complex. Again, it just fired early. We didn't add an additional complex. It just fired normally or earlier than it normally would. A lot of times, treatment-wise, patients aren't even going to notice they have them. You might think they have an irregular heartbeat, or you might only ever see one of these on their strip. Again, caffeine, stress, unhealthy lifestyles can lead to PACs. Treat the patient, not the monitor, with this in this aspect. What was that, Tanya? Did you have something?
No, I said sometimes when they're dehydrated too.
Yeah, absolutely. Okay, a junctional complex comes from the AV node. Anytime you hear the word junctional, it's not coming from the SA node. It's below that. What do I notice about this rhythm here? What's abnormal about it?
You have a longer pause in between.
Okay, long pause between which two?
So you have, so you have a regular rhythm, and the third one is actually a faster in between. So then it's a longer pause in the fourth one.
Okay, so it's actually the fourth one comes early, but we have a long pause afterwards. I see what you're saying.
Yes.
So, but what do I notice about this complex that it doesn't look like the others?
It doesn't have a P
No
wave.
P wave.
It doesn't have a P wave. So, did it come from the SA node?
No.
Nope.
It did
Came
not.
from the AV node.
Most likely it came from the AV node because it's still narrow. SA node and AV node will still make narrow rhythms. Okay, again, this could be caused by lifestyle changes. When I say treat the patient, not the monitor, if they're tachy, you might have to treat their tachycardia. If they're brady, you might have to treat their bradycardia. It really just depends what their underlying rhythm is. Now, when I classify this, without looking at that, say that as a 6-second strip. What's my heart rate on average, would you say?
60.
60.
You'd be safe to say between 50 and 60. How I would classify this then is that as sinus brady, because my other complexes do have P waves, right?
Correct.
Sinus brady with PJC. That's how I would classify the rhythm. And that's how I would give it my report as well. As, I've got a 55-year-old female. She was complaining of nausea and vomiting, not feeling well. We put her on the cardiac monitor. Patient was found to be in sinus bradycardia and did have an occasional PJC. And that right there tells them everything they need to know when it comes to what's going on with our patient.
Hey, Rudy.
What was that?
Hey, how often, do these ever hurt somebody? Would
Not
they
so
be
much.
symptomatic from it or no?
They can, and I guess I'm guaranteeing everybody here has probably had one at some point or a PAC at some point. You ever felt like your heart skipped a beat?
Yeah.
That's what's happening.
Okay.
Your heart's not skipping a beat. It just has that long pause between them, and then you have a really big one because the blood was filling up. That's what you're feeling. That will generally, when I say generally, remember, patients can present with all sorts of different symptoms. This generally won't cause any major issues with your patient. This generally won't be the underlying cause of some huge issue your patient has, unless they're complaining of dizziness or not feeling well. Yeah, this could potentially be the cause because, remember, we have a rhythm that is irregular now due to a premature beat. But it's still narrow. Again, narrow rhythms come from above what?
Atrium.
Nope.
Ventricle.
Above the ventricles. All narrow rhythms come from above the ventricles. So we've covered PAC, we've covered PJC. This is what a PVC looks like. Way different than anything we've ever seen. And now you can see the difference when I say narrow versus wide. So I've got narrow complexes here, right? We see them, no big deal. But then what about this big trucker here? What's going on there? Why is it wide, for one?
Came from the ventricles.
Okay, but why what makes it wide though?
More space for the electricity to spread around.
Nope. Remember, that equals distance. It takes that much longer to travel through your ventricles. So yeah, there's more space, but it's due to the delayed how long it takes to get through your ventricles.
So it's actually firing wrong in the atrium.
It's actually what?
Firing wrong in the atrium. So it's
Nope. That's not from that wide rhythm is not from the atrium or the AV node. That is strictly from the ventricles. Anytime you have a wide rhythm, think ventricles. PVCs, again, can be a little more of a concern, to be honest, with patients. If we have more than 3 PVCs in a row, we can classify that as a run of VTAC. And VTAC is, I'll get to that rhythm here shortly, but that's a cardiac arrest rhythm. So anytime you have 3 PVCs in a row, it's a run. If I had a rhythm in every other beat was a PVC, I would call that bifocal PVCs because every two beats, bi meaning 2. If every third beat was a PVC, it'd be trifocal PVCs. So 1, 2, PVC is trifocal. 1 PVC, 1 PVC is bifocal. Now, the problem is if our patient consistently throws PVCs, that's a really good indicator that our patient could potentially be trending cardiac arrest. Most likely due to an issue within the heart or due to an electrolyte issue. Remember, what are our two big electrolytes that have to do with our heart functioning when it comes to electrical discharge? What are those two electrolytes?
Sodium and potassium.
Sodium and potassium, abbreviated Na and K. Remember, please remember sodium potassium pump. That's how our heart discharges electricity. Does everybody understand that a ventricular beat is wide?
Yeah.
Okay. Here's my example of my bigeminal PVCs. They're bifocal PVCs. Either way, every other beat is a PVC. And see, those don't look like the last ones, but it is still wide. What's my normal QRS duration that we have to stay within to be classified as narrow?
0.08 to 0.12.
0.08 to 0.12. Now let's zoom in on this and see if I can even figure out how to zoom. There we go. From the point that I get my first positive reflection to the point my S wave ends, how many small boxes is that?
Five.
It's closer to 10. So remember, we're looking, let me get my eraser. For our QRS complex, I'm looking from here to here because that's the width of my rhythm. That is my complex, as opposed to here to here. 10 small boxes is 0.40. Anything above 0.12 is a wide rhythm. Anything above 0.12, I don't care what it is. Anything above 0.12 is a wide rhythm. And then there's my trigeminal PVCs. Every third beat is a PVC. So 1, 2, PVC, 1, 2, PVC, and that'll continue. 1, 2, PVC. To me, as a paramedic looking at that on a monitor, that makes me a little uneasy. Because again, this patient is potentially could go into cardiac arrest or is really having some heart issues. And they'd have to be put on like an antiarrhythmic. So these kind of go hand in hand with what I was just talking about. And this is the bread and butter of ACLS, which is advanced cardiac life support. And it's identifying cardiac arrest rhythms and knowing how we treat it. Obviously, you guys don't go through ACLS till third semester, but you have to know your rhythms to be able to pass ACLS. All these rhythms I'm going to throw at you are all cardiac arrest rhythms. But your patient can be stable in some of the rhythms and not truly in cardiac arrest. So you've really got to monitor your patient. First rhythm up, VFib, or ventricular fibrillation. You might see abbreviated as such. Will look pretty close to what you see here. Very sporadic, not organized. What do you think is happening within the heart?
Spasming.
Yeah, spasming or quivering. That is the heart spasming, or quivering. Okay, 9 or 10 times out of 10, if your patient is in this rhythm, they will not have a pulse because there is no complexes. There's no heartbeat. Heart rate is 0 at this point. This is also what's called a shockable rhythm. We have 2 shockable rhythms in cardiac arrest. We have VFib or VTAC. So you ever put the AED on somebody or your monitor, whatever it is, and it says shock advised? They were in this rhythm or another one, known as VTAC. And that's, again, because their heart electricity is not functioning properly. So by defibrillating, we're hoping to Control-Alt-Delete and reset it. Now, you can also have fine VFib, which looks like such. So just be careful of that, as opposed to asystole, which is your perfectly flat line. Always pulseless, most immediate treatment. Obviously, we're starting CPR on this patient. As soon as we can, we need to defibrillate. So that's VFib. Another common one, VTAC. If you've ever seen it, has anybody seen VTAC on monitor before?
Yes.
Okay. Abbreviated as such, VTAC, which is ventricular tachycardia. Remember, these complexes are wide. So it's from the ventricles, and it's fast. This is classified as monomorphic VTAC because they all look the exact same. Again, this is a shockable rhythm. The treatment is the exact same for VFib if the patient is in cardiac arrest. Now I'm going to throw this at you. Can a patient be in VTAC and have a pulse?
Yes.
Absolutely, they can. And this could happen to you. You go to pick up a patient. They feel like they're going to pass out. They're not feeling right. You come up to monitor and you see this rhythm. That happened to me early on in my career, and I immediately froze and looked at the monitor and yelled for my partner to come back there instead of drive, because I had a patient who's in a cardiac arrest rhythm but has a pulse and is stable. Blood pressure was fine. When we have this rhythm, either they are pulseless or they have a pulse. If they have a pulse, we have to determine, are they stable or unstable? Stable, we treat with medications. Unstable, we treat with electricity. If you've ever heard of cardioversion or synchronized cardioversion, this is a rhythm that you could cardiovert if the patient has a pulse. Looking back at our drug cards, what little we know about pharmacology, what medication do you think could be used to treat this rhythm? Begins with an A.
Amiodarone.
Bingo. Amiodarone. Amio. If this patient is stable, how do I give amio? What's the dose for stable VTAC? Does anybody know?
Is it 300?
Nope, that's for cardiac arrest.
150.
Okay, so 150 milligrams is the dose.
Is it 150 on a drip over 10 minutes?
Yes. So you can either take amio, which comes in like a little vial, and slowly push it over 10 minutes, or you can take a bag of fluid, put the amio into the bag, and drip that bag in over 10 minutes. Again, almost every single protocol will say that because we follow ACLS when it comes to these rhythms. On my patient that I had that was stable in this, I actually called medical direction, and you're not wrong to do that. I said, hey, this patient is stable. I am afraid to sneeze at this point because I thought the guy was going to go south. And the doctor said, if he's fine, just bring him in. Don't mess with him. So literally, I started an IV and just treated this guy on my way to the hospital. The funny part is, halfway to the hospital, I kept checking on the guy, and like literally, when I say checking on him, I'd look to see if his eyes were blinking. And I said, "Hey, has anything ever happened like this before?" Like, and he goes, "Oh yeah." And I said, "Okay, what happened last time?" He goes, "Well, I ran out of my prescription of amiodarone." Bingo. He's on a medication to control this. But you have an unresponsive patient that's in this rhythm, I'm guaranteeing they're pulseless. Start CPR and shocky. Has anybody ever seen that meme on Facebook? I don't know what movie it's from or whatever, but I always see it all the time, and it talks about like when you're a paramedic student and it holds up a rhythm, and it's like, I think it's like a penguin or something like that. It says kaboom, and then it says yes, Rico, kaboom. Has anybody ever seen that? I'll just send it to you guys. It's this is what they're talking about when he says kaboom. Yeah, that's the rhythm that we shock. So we had monomorphic, mono meaning one. We can also have polymorphic VTAC, otherwise known as torsades de pointes. That is French for twisting of the points. You might honestly just hear this called torsades. Torsades is a very unique rhythm, and it's not a very common one. But this is a cardiac arrest rhythm. The patient will not have a pulse in torsades. Easiest way that I remember torsades is it kind of looks like a sound wave. That's how I remember it. Monomorphic VTAC all looks the same. Polymorphic VTAC looks different. Anybody guess, in addition to shocking and doing CPR, what our treatment is for a patient in torsades? It's a medication we all carry. It says it right there in that paragraph.
Mag sulfate.
Yep. Mag sulfate. Torsades, 9 times out of 10, is due to a magnesium deficiency. So we give mag sulfate to hopefully try to correct that. But also we still work it. CPR, defibrillation, we just can give mag during that whole process as well. This should be one we all are familiar with. This is no shock advised. What is happening in the heart in asystole?
No electrical activity and it's not beating.
I have no electrical activity and I have no mechanical squeeze, right? A patient in asystole has really, really slim chances of getting ROSC. Really slim chances of getting them back. Break down the word asystole. Anytime that we have a word with A in front of it, what does that usually mean?
Not.
So without systole, without ventricular squeeze. You might also hear this referred to as cardiac standstill. What I will tell you is if you see this rhythm, just double check and make sure your leads are on. Make sure that you didn't, like, a lead didn't fall off or something like that. Asystole is not a shockable rhythm. There is nothing to control alt delete. This is essentially a computer that you can't turn on, that is just black. Nothing's working. You can't reset it. Treatment, CPR, and medications. Now, we can have patients in PEA, or pulseless electrical activity. How do I know that a person is in PEA? It's a really easy answer.
No pulse.
They don't have a pulse. I feel like you might have heard that a time or two today. They don't have a pulse. So I can have electrical activity that looks normal. I have the patient on the monitor. I see that. I'm like, okay, yeah, things look great. It'll even show their heart rate 70 because it's picking up on the electrical activity within their heart. But yet, the mechanical portion of their heart is not working. You might see this abbreviated as PEA. Very similar to asystole. We cannot shock this. Junctional rhythms. Who can tell me what a junctional rhythm was? Where's it coming from?
AV,
AV node.
Okay, so what does it lack? What does it not have if it's coming from the AV node?
P wave,
Won't have a P wave. No P wave. So, with that being said, if it's coming from the AV node, what is our rate going to be, you think? Between what and what? Between 40 and 60, roughly. So a normal junctional rhythm is between 40 and 60. You can have accelerated junctional, which is anything above 60. You can break it down even further and call it junctional tach. For the sake of identifying rhythms, it's just a tachy junctional rhythm if it's above 60. Here is a example of a junctional rhythm. Do you see a P wave there? What do you notice about that P wave?
inverted.
Press.
Yeah, it's upside down, right? If you have a P wave that is absent or upside down, it is a junctional rhythm. It has to be all of them. It can't just be one. All of them have to look the same. Either all are absent or all are upside down to be a junctional rhythm. Still narrow because it's coming from above the ventricles. Here's an example of a faster rhythm that's junctional. Let's say this is our 6-second strip. 1, 2, 3. What's my rate?
80.
Okay.
80.
Which would be a normal thing if it was from the SA node, normal rate if it was from the SA node, but it's not. So this would be classified as accelerated junctional or junctional tach because there is no P wave and it's a fast rhythm from the AV node. All right, rest your minds for a second. We're going to talk about pacemakers. Pacemakers are important for us to know what they do, and they're easy for us to identify once we know what we're looking for in a cardiac monitor. But what are some reasons that a patient would have to get a temporary pacemaker? And Tanya, you might know. It's not just due to a fast rate. That's more of a on-demand pacemaker. But what are some reasons we put a pacemaker in somebody? What issues are they potentially having?
Irregular heartbeat or electrical firing.
Okay, could be to an irregular heartbeat. What else? What's most common?
AFib.
Okay. How about this? If they have a slow heart rate, usually they get a pacemaker to speed it up. It's pretty common. So how does a pacemaker function? You know, they're actually kind of terrifying if you think about it, because a pacemaker has these leads. Maybe it's your atrium not firing correctly, maybe it's your ventricles not firing correctly, and these little leads are implanted into your heart. Think of like two wires, right? What happens when I touch two like if I took a positive cable off a battery and a negative cable and I touched them together really quick, what would happen? I get a spark, right? So I have this negative and I have this positive cable in different parts of my heart, depending on if I have an atrial problem or a ventricular problem. And they detect if there is any electrical activity. If there isn't, they generate their own impulse. And they force the heart to contract. Looks very similar to this. There's your electrode tip that would be implanted either in the atrium or the ventricles, depending on where the patient has a problem. Where do we usually see a pacemaker on patients?
Kind of right underneath the clavicle, isn't it?
Yeah, yep. And it's
On
usually,
the inside, usually.
it's usually like a kind of a raised area, right? They're really definitive. You can really tell what it is. It's like a lump essentially right there. The patients will generally know that they have a pacemaker. Most common reasons we do pacemaker, not for irregular heartbeats, not for AFib. Most commonly is heart blocks and bradycardia. Heart blocks can cause bradycardia, so they kind of go hand in hand. So different types of pacemaker. Obviously, we can have an atrial pacemaker, so meaning our atrium is not generating its impulse correctly. So we put an atrial pacemaker in. We can have a ventricular pacemaker, meaning our ventricles aren't working correctly. Or we can have what is called an AV pacemaker, which means my atrium and my ventricles aren't working correctly. So I now have to control everything. So this is what a pacemaker looks like on a patient. This is a normal rhythm. I will have a pacer spike followed by a P wave. That is my jolt of electricity, and then that is my SA node picking up on my electricity and passing it down. Everybody see that pacer spike and then that P wave after it? Knowing if I saw that, I'd know right off the bat that that is a paced rhythm. This is an example of a ventricular paced rhythm. So back here, I had atrium paced because it's right in front of my P wave. This one is in front of my ventricles because it's right in front of my QRS complex, and it is wide. My complex is wide, meaning it is a ventricular beat. So this would be an example of a ventricular pacemaker.
If you had an AV one, would you have a jolt of electricity in front of both then?
You tell me. What do you see there?
2 jolts of electricity.
So I've got a pacer spike in front of my atrium for my P waves, and I've got a pacer spike for my ventricles. They're very definitive and very easy to tell on a 3 or 4 lead. You can look at that, and the problem is you'll look at that right off the bat and go, oh my God, they're in a wide rhythm, until you see that they're being paced. Nothing to terrify you. Does anybody know, and I bring this up because it's a National Registry question, not because I ever recommend it. Does anybody know how you shut down a pacemaker?
Magnet.
A very large magnet. Some places carry them in their ambulances. Most people have gotten rid of them because if we shut down the patient's pacemaker, we then have to take over that electrical impulse somehow. But a lot of times a magnet will shut down the pacemaker. It's just placed right over the pacemaker to deflect any charge. And it's done in instances of a pacemaker failing, such as what you see here. You can see I have pacer spikes, but nothing following it. That a lot of times is a pacemaker not essentially failing, but not dialed into the patient, really. When it comes
Like
to
the
pacemaker. What was that?
Like the lead is slipped.
Yeah, right. And you can see the pacemaker, if you looked at those spikes, they're beating along at a normal rate. But they're not capturing on every beat. So that would be a pacemaker failing to capture. Because I don't have a complex behind all my spikes. In this instance, this is a pacemaker, again, that is not, and when we talk about pacemakers, they really have to be set to the patient's own electrical activity. If they're not, they can fire randomly. The problem is if I have a pacemaker which introduces electricity to your heart randomly, I've essentially got a little mini AED, right? Fulton, what would happen if I put AED patches on you right now and hit shock?
Throw me out of rhythm.
Kaboom, Rico. That's what I'm saying. So it's going to shut you down. It's probably going to put you into cardiac arrest. That's what happened here in this instance. Pacemaker wasn't firing like it should. It shocked at the wrong part in the heart, and the patient went into this rhythm. What rhythm is that?
VFib.
VFib. Okay, so looking at these strips, this is just having to do with pacemakers. What would you guys say? What type of pacemaker is this that this patient has?
Atrial.
Okay. Tell me why.
Got that extra little, almost looks like a complex.
Okay.
The actual QRS.
Okay. It's right in front of my P wave, right?
Yeah.
Does it look like it's capturing on all my complexes?
Yes.
Yeah.
Okay. Okay. Normal atrial paging. Good job. All right. Somebody else, take a look at this and tell me what you see. Ooh, this is a tricky one, huh? Use our principles. Is there a P wave for every complex?
No. No. Yeah. Yeah.
Okay. P wave for every complex. Is my QRS narrow or wide?
Narrow.
Okay. Let's say this is a 6-second strip. What's my rate?
$180.
Okay. We'll say between 170 and 180. But I can tell the difference between a P wave and a T wave, can I not?
Yes.
I'd just call that sinus tach.
Hmm.
Now, sinus tach is, again, remember, can be a compensation method for something. This could be a patient that's in pain, the patient that's in distress, or it could be a patient that's in shock. Sinus tach is not a normal rhythm unless, you're like me and you just walked up a flight of stairs. There's a reason the patient is in sinus tach, and we have to try to figure out why. All right, let me go back to that video that kind of walks through looking at different strips. We'll watch this video real quick and we'll kind of talk about it. Again, I'm just trying to get you guys in the mindset of reading a rhythm strip. If one thing sticks out to you, either something that I've said or something in this video, I'll be honest, this guy's voice is kind of annoying. He gets a little too excited. But maybe it sticks, maybe it won't. Video's about 12 minutes long, so just kind of sit back, relax, and if you have any questions afterwards, just let me know. Let me make sure that I'm sharing my sound real quick. And then when it starts going, if somebody could just let me know you guys can hear this.
What is going on, guys? Dawn checking in. Welcome to
Yep.
MIT, where we bring nursing to you.
You say yep?
Yes.
Perfect.
So today we're going to talk about the easiest way to do your EKG interpretation. So if you're a nursing student or a new nurse who wants to do your EKG faster, stick around. This video is for you. Alright guys, this is the 6-step EKG interpretation. So before we talk about the actual steps, we're going to discuss important concepts that will help us have a better understanding of what's going on inside the heart as it generates a heartbeat. The first concept that we are going to discuss is the conduction system of the heart. Now, the conduction system of the heart is pretty much these special cardiac cells right here that are responsible in conducting signals that cause the heart to contract. The first cell is called the SA node, right here, or the sinoatrial node. By its name, sinoatrial, this cell is found within the right atrium of the heart. This is also known as the natural pacemaker of the heart, because this is where the beginning of the conduction takes place. So from the SA node, the conduction goes to the AV node, or the atrioventricular node. By its name, this can be found within the border of the right atrium and the right ventricle. The AV node is also known as the gatekeeper of the heart. And the reason being is that it gets to decide what impulse to let through. So, if the SA node generates a weak impulse, or there is a block here somewhere, the AV node will perceive that and will decide not to let the impulse go through, and instead it will conduct its own impulse. So from the AV node, it goes to the single structure right here called the bundle of His. And from the bundle of His, the cells will continue and will bifurcate into two separate cells, one to the left and one to the right. And this will now be called the left and right bundle branches. And from the bundle branches, they will extend within the apex of the heart. They will be called the Purkinje fibers. So again, the conduction system of the heart begins at the SA node, goes to the AV node, next is the bundle of His, the right and the left bundle branches, and then eventually Purkinje fibers. So another concept that we need to discuss will be the inherent rate of these cardiac cells. When you say inherent rates, these are pretty much the heart rate that we generate depending on which cardiac cell sends an impulse. So for example, if the SA node starts it all and it goes all the way to the Purkinje fibers, this will generate a heart rate of 60 to 100 beats per minute. It starts from here, goes all the way to the Purkinje fibers, that will generate a heart rate of 60 to 100 beats per minute. However, for some reason, if the SA node fails or there's a block somewhere here, then the AV node will kick in. It will generate its own impulse. And when this happens, the AV node will generate a heart rate of 40 to 60 beats per minute. And that also includes the bundle of His. The bundle of His also will generate its own impulse, and it's enough to make 40 to 60 beats per minute. And if the AV node or the bundle of His fail, then the left and the right bundle branches and the Purkinje fibers will generate their own impulse, and they have the capacity to make a heartbeat up to 20 to 40 beats per minute. So now, let us talk about EKG. It has different parts. We will start with this small bump right here called the P wave, followed by this tall structure right here called the QRS complex. And lastly, the last bump after the QRS complex would be the T wave. Let us discuss them one by one. Let's start off with P wave. The P wave represents atrial depolarization. During atrial depolarization, the two atria are contracting. Next up, the QRS complex. Now, the QRS complex represents ventricular depolarization. During ventricular depolarization, the ventricles of the heart are contracting. Depolarization is for contraction. So how would you know which one is which? That P wave is for atria while QRS is to ventricles. So if you look at the diagram right here, the QRS complex, it kind of looks like an inverted V. So V for ventricles. So when you see a QRS complex, think about ventricular depolarization. So lastly, we have the T wave. The T wave represents ventricular repolarization. This is when the ventricles are relaxing. Keep in mind that every depolarization is always followed by repolarization. So for every contraction, will be followed by relaxation. That being said, the question is, where is atrial repolarization? So if QRS represents ventricular depolarization or contraction, and T wave represents ventricular repolarization or relaxation, then where is atrial repolarization if this is depolarization? Well, it can be found within the QRS complex. As you can see, the QRS complex, it's a tall structure. Because ventricles tend to contract stronger than the atria, they tend to mask the atrial repolarization. And so, that being said, atrial repolarization and relaxation takes place after the P wave, which can be found within the QRS complex. Now, as a review, P wave stands for atrial depolarization. The QRS complex represents ventricular depolarization. The T wave represents ventricular repolarization, and the atrial repolarization is covered by the QRS complex. You can't see it, but it exists. So now let us talk about the segments and intervals in the EKG diagram. There are a bunch, starting off with the PR interval, the PR segment, the QRS complex, the ST segment, and the QT interval. But to make it easy for you guys, we are just going to talk about the PR interval and the QRS complex. These are all you need to do the EKG interpretation. The other segments, they are important too, but we don't really need them to interpret an EKG faster and more efficient. So this is your typical EKG strip. In an EKG strip, we have a big box. And inside a big box, we have 5 small boxes. Each small boxes is equal to 0.04 seconds. And so if in a big box there are 5 small boxes, that means that one big box is equal to 0.20 seconds. But really, as long as you know that one small box is 0.04 seconds, we're good to go. So let us get on with our 6-step EKG interpretation. First up, we have to identify and examine the P waves, measure the PR interval, measure the QRS complex, identify the rhythm, determine the heart rate, and interpret your strip. And we're going to talk about them one by one. Let's start off with identify and examine your P waves right here. The normal P wave would be present and upright. If the P wave is absent or inverted, then it could indicate a form of dysrhythmia such as a junctional rhythm. Next up, we are going to measure the PR interval. PR interval is the distance between the beginning of the P wave and the beginning of the QRS complex. What we do is we count the number of small boxes in between and multiply it by 0.04 seconds. Our magic number for the PR interval is 0.12 to 0.20 seconds. Anything more than 0.20 seconds could indicate another dysrhythmia such as heart blocks. Third would be to measure the QRS complex. Just like the PR interval, we are going to measure the small boxes in between the QRS complex. Our magic number is 0.06 to 0.12 seconds. Anything more than 0.12 could indicate a dysrhythmia such as a PVC. Number 4 is we have to identify the rhythm of our strip. It could be regular or irregular. And the way we do this is we measure the distance between R's and R's. Some people use calipers to do this, but really all you need is an index card. Mark your R's and march them with the rest of the R's. If they have the same distance, then your rhythm is regular. Otherwise, they are irregular. Fifth step is when we identify our heart rate. Now, before we calculate our heart rate, it is very important for us to know that our EKG is a 6-second strip. And the way we will know this is when we find these 3 lines right over here. If you see these lines, this means that from the first line up to the 3rd line, that would be your 6-second strip. The reason why this is important is that if it is a 6-second strip, then we can do a technique called the 6-second method. And the way we do this is that we count the number of R's between these three lines right here and multiply them by 10. So for this strip, we have 1, 2, 3, 4, 5, 6, and multiply that by 10. That will give us a heart rate of 60 beats per minute. One thing to remember is that this method works best for irregular rhythms. And another tip that I can tell you is that you have to be very, very careful in using the 6-second method. You always have to verify that the strip that you're reading is indeed a 6-second strip. I know some teachers include strips that appear to be 6-second strips, but they're really not. They don't have these 3 lines right here. And students actually mess up the heart rate because they use the 6-second method. This method only works for 6-second strips, okay? Second method that we can use to calculate the heart rate is the big box method.
Okay, I'm going to skip past this portion because I don't want you guys to learn this yet until we get to 12 leads, which I can play it, but if you don't understand it, please don't freak out because we usually don't teach this till later on.
And the way this works is that we divide 300 by the number of big boxes between 2 R's. Our magic number is 300. So for this strip, we are going to use these 2 R's right here. We have 1, 2, 3, 4, 5 big boxes in between R's. And so, using the formula, 300 divided by 5, we have 60 beats per minute. This method works better for regular rhythms only. And this is actually the method that you can use if you don't have a 6-second strip in front of you. And the final step is interpret your strip.
So that is it for today, guys. I hope you find that helpful. And if you haven't already, please hit the like and subscribe button. And let us know in the comment section below if you want to.
I don't think I'll be subscribing. His voice drives me nuts. All right. I told you guys I'd keep you fairly short tonight. 8 minutes till 8. I don't want to, again, overwhelm you. I think tonight was a good review of some of the stuff we covered last week and, introducing cardiac arrest rhythms and pace rhythms. As far as anomalies for 4 leads, there's really nothing too crazy that we're going to add on top of what I haven't already went through. So next week, I want to start going through 12 leads and the very basic intro to 12 leads, like looking at different leads and what they pertain to in the heart. And that is pretty vital that you understand as well, because a big part of what we do isn't just interpreting 3 leads and 4 leads, but knowing that in our chest pain patients, we might have to do a 12 lead, or our patients that are experiencing a syncopal episode, or maybe feel like they're going to pass out, is doing a 12 lead on them. What questions do you guys have for me tonight?
Hey, Rudy, in that video, they referenced 0.06 to 0.12 seconds for the QRS complex. So
it's changed. It's 0.08.
Okay, perfect.
It used to be 0.06. It's now 0.08. Does anybody feel like you were able to get a little bit better grasp on some stuff, kind of going over a review on it? That's my hopes.
Yes.
Yeah.
And I know that again, cardiology is a lot to soak in, and we're barely brushing the surface. Remember, when it comes to cardiology, when it comes to any subjects we're going to talk about in medical emergencies, we're going through the very basic knowledge to be able to function as a paramedic. You can go as far into cardiology as you want. And I won't throw some terms or anything at you to scare you, but there's so much to be learned with cardiac by us as paramedics. And it's one thing that, again, and you guys have probably heard me beat this drum I don't know how many times, we should know how to do efficiently. We should know how to do effectively, because I'd say 7 out of 10 patients that we treat potentially have cardiac issues. So why are we not training more on cardiac problems that our patients have? Just my 2 cents for the night, I guess. Any questions before I break everybody up? Homework. I'll give you, let's see, a week should be fine. I have those 2 different worksheets. I have the heart labeling worksheet, and then I have the coronary artery worksheet. want you to go through those, complete those, and send them to me, because that is part of your homework. Just even if you just need to take a picture of them and send it and email it to me, that's fine. But I want you to keep them for reference as well, to help you study or get through 12 leads or anything like that. All right, anything for the good of class before we go? All right, like I said, I kept it short for you guys. I didn't want to overwhelm you on the second night, because the first night was a little much. 3 hours and 43 minutes was the first night. Kept it around 2 hours for tonight. I'm good with that. If you guys don't have any questions, have a great rest of your night. I'll see you guys in lab, or I'll see you next Tuesday, or whatever it might be.
Thanks so much.
Thank you.
Thanks, Rudy.
Thanks a bunch.